You're listening to the Fertility Docs Uncensored podcast, featuring insight on all things fertility from some of the top-rated doctors around America. Whether you're struggling to conceive or just planning for your future family, we're here to guide you every step of the way.
Hello, this is Dr. Carrie Bedient from the Fertility Center of Las Vegas, and I am here for another episode of Fertility Docs Uncensored, joined by, of course, my two delightful, lovely, and fantabulous colleagues, Dr. Abby Eblen from Nashville Fertility Center.
Hey, everybody.
And my equally as lovely, fantabulous, and wonderful colleague, Dr. Susan Hudson from the Texas Fertility Center.
I love being fantabulous.
I mean, everybody should be fantabulous at least once a week, just for the hell of it. And I am super, super excited about our guest this week because not only is she beautiful and stunning and witty and charming and all of the delightful adjectives that fantabulous. Of course, I mean, that goes without saying. But Dr. Shannon Ho is here with us today. She is a maternal fetal medicine specialist at the Maternal Fetal Medicine group at Ohio Health, which is a really phenomenal, huge group in Columbus, Ohio. And more importantly to me, she is one of my former co-residents. And so we went through a really grueling 4 years together at Metro Health in the Cleveland Clinic. And so it is pretty fabulous to have Shannon here both in the professional world and because I just love hearing her voice. So thank you for joining us, Shannon.
Thank you. I appreciate it so much. I was really excited and pumped to be part of the program. Thank you.
Well, we are just super excited to have you here. And we were just talking about your practice, which sounds like it is absolutely ginormous. I mean, especially for an MFM group where, at least in my context, I don't think I know of very many groups that are over 4, 5, 6 people or so.
Yeah, that's huge. 10 people, right?
Yes, we just hired our 10th, looking possibly for the 11th partner next year. So we have the honor and privilege of touching a lot of pregnant women and helping them throughout their pregnancies. And we see a wide variety of patients as well. And one of our real important components is we see a lot of patients who've had fertility treatment. So this is right in our wheelhouse. And we always like it when you guys get them tucked in and get things going. And then a lot of times we step in and kind of help with the next phase of care.
When I hear that, though, it kind of makes me think, okay, but I don't want to send you triplets or heaven forbid quadruplets. When I say, when we send people to you, usually we're kind of nervous when we send them to you. We're like, oh, please let everything turn out okay.
Well, I know. We're always happy to see multiples. That's always in our wheelhouse. And we are real comfortable with that. But yeah, I have some of the REIs here. They're kind of like, take good care of them. I'm passing the baton. And so
that's right.
So Shannon, what else do you do outside of your doctor hat?
Yes. So I love to garden. I'm an avid gardener. I got into English roses as a matter of course.
Wow.
Mainly because they have less thorns and they're less prickly, but I found I love to nurture and love things. And so, this kind of needy plant just appealed to me.
Well, I was going to say, roses are some of the hardest plants to grow, right? Because they have all kinds of bugs and they're very particular and
kind of finicky, they have to have just the right balance of everything, but it's a labor of love and I enjoy it. I have 3 boys as well, so they are usually out, and I use air quotes here, helping me. So sometimes their help hurts. So if you're a plant here on the homestead, you got to be kind of tough.
So do you grow anything other than roses?
I've really not met a plant I don't enjoy. So I have a big mix of perennials because albeit roses are great, but, they kind of have a flush and then they're gone. So that would be kind of boring if that was, the only plant. But I do a lot of perennials and annuals. And I also have a little garden mainly focused on tomatoes and peppers and a few eggplants and things like that thrown in there. So
wow.
I'm also the tomato lady of the cul-de-sac. It never fails me. I'll get right at once. And so I'm like, hey, you want a tomato? If you don't want a tomato, how about a pepper? Can I give you a pepper? So
you're a vegetable pusher. That's what you are. You are a vegetable pusher.
I am.
I'm not very good at growing vegetables, but it's kind of a long story, but it's sort of a community garden that I'm working with a master gardener. And he's very interested in getting rare seed. So he has this rare seed catalog. And literally, I mean, he told me what to do, he and my daughter and I. And he literally showed us how to plant these tomatoes from seed. And of course, he did all the other work. He like nurtured them and watered them and put them under the grow lights. So we actually got to see them, sprout up and produce tomatoes. It was pretty cool.
Did the tomatoes taste better than other garden varieties?
They really did.
They always do.
They were really rare breeds, like out of this special seed catalog. And you literally got, tomato seeds that you planted. And so I felt like I was, working with like Hope Diamonds or something, when we were planting these seeds. I didn't want to drop a seed anywhere. So, but it was cool. They were delicious. We ate a few of them. I got a few of them and they were really good.
Yeah, I kill succulents.
Carrie and I are in the same house.
No, you don't. You grow succulents, Carrie. You said you grew a lot of them. Did you lie?
I was doing really fabulous. And then we hit a couple of heat waves and we're getting smoke from the California wildfires. And so the air quality is for crap. And we've had these big bursts of high heat, like higher than typical for here. And so now out of my probably some 50 succulent plants that I planted maybe a year ago, which of course are all still small because they grow slowly, but I have maybe a handful left. Like all the poor little guys died. My inside ones are still alive. Thriving is a strong word, but they are alive. But my outside ones are just cranky as all hell. And I think most of them are not going to come back, sadly.
As a side note, though, Carrie, every time Sunday is my watering day, and every time I go to water my plants now on Sundays, when I water the succulents, I hear your little voice going, "Water is the enemy for succulents." I keep hearing that. So I put just a little less water than I was going to otherwise.
Excellent. Yeah, they probably get far more in Nashville just from the ambient air and rain, and humidity and all that stuff than they do in Vegas.
Yeah.
But all right. So Susan, do you have our question of the day?
I do. So our question is, would I make things extremely awkward at the fertility clinic that I'm using if I asked for a different IVF nurse assigned to me? I am finished with stimulation and I'm dreading having to work with her during the FET cycle. My IVF nurse is knowledgeable and experienced, but she's very lacking in compassion or bedside manner. She's always in a rush and it just seems like I'm an item on her checklist to get through. I've seen other nurses during my stimulation cycle and they were also kind of explained what to expect. I think I have called to ask her questions 2 to 3 times during this entire process, and she seems very annoyed with me every time. When I asked her how to calculate a due date after an FET cycle, she said that the embryo transfer wouldn't necessarily be successful, so maybe I don't need to estimate the due date. The clinic does seem understaffed, so I'm sure that doesn't help her mood. My nurse went on vacation during the stim cycle, and I was having to repeatedly call to figure out which medications to take and what time to take my trigger shot. Maybe she didn't remember to hand over my file to someone else, since there are a couple of days where I had to try and find somebody to talk to, finally getting someone on the phone as the office was closing. One of those days, a nurse said I needed an extra dose of medication, but it was so late in the day that I couldn't get it overnighted in time. Luckily, they had one single syringe of what I needed in the office. It was an awful week. Oh, my heart goes out to this patient.
That sucks. What do you think, Abby?
Well, I think, not everybody clicks with everybody else. And, unfortunately, we're all human and things happen. And so, I just think if it's a doctor or a nurse you don't click with, you probably ought to find somebody else. And I think offices are different in how they do this, but we're pretty open to, if you don't click with a nurse, let us know and we'll put you with another nurse. Or if you had a bad experience with that nurse, we'll let you go with another nurse. And the same thing even with doctors. I mean, we would rather keep you at our practice and let you, switch to a different doctor that you like better. And we don't hold it against you or anything. So yeah, I think it would be perfectly fine to ask to switch to a different nurse.
I completely agree. I think if there's somebody else for you to switch to, and especially if there was somebody that you worked well with when she was absent and you can specifically say, hey, can I work with somebody like this? I think everybody in every clinic recognizes that some people get along with some people and some people don't. I always, as much as I never want to get quote constructive criticism, I always appreciate it though, because I can't fix things that I'm not aware of.
Yeah. It's always hard to get criticism for sure, but it's
always hard to get it, but I would rather hear about it and be able to address it than necessarily it to be happening over and over. And that the only time I would ever find out about it is when it's on a Google review. I would much rather have the chance to make the rest of your experience better and to be able to address with my staff, hey, maybe this interaction wasn't the best, and use it as a learning and education tool.
Mm-hmm. And nurses get burnt out too. I mean, this is a demanding field for everybody who's in it on both sides of the equation. And some of the most telling things that we have been able to enact to help our staff have been when we get repeated comments about someone that we ordinarily never get a repeated comment about. That tells us like, okay, we need to do something, whether it's hire another person or switch workloads or whatever it may be. It's actually a really important piece of information for us, not just for you and your care, but to make sure that all of our patients are getting good care. So, as always, be polite and be mindful about it and say, I really don't want to trash anybody. I just think that I need a little bit more warm and fuzzy in order to help me get through this. And so could I maybe work with someone else? Now, as always, listen for subtext, because in every clinic, there's always going to be a couple nurses who are the most experienced, who really know what they're doing, and who can be very helpful in particular patient scenarios where the doc knows I'm going to be throwing more curveballs and this nurse is going to handle it better. And so even if they are not necessarily the warm and fuzziest, if they're medically going to get you there, that's always something to think about. So, if your doctor seems resistant, you may want to listen for that subtext, because ultimately the goal is to get you where you want to be through your IVF cycle and all of that. And, with compassion and perfectly executed is the ideal, but certainly talk about it with your doctor. You have nothing to lose and everything to gain.
Totally agree.
All right. So today we are going to be talking with the lovely Dr. Ho about what to expect after you have your IVF pregnancy established. So you have made it all the way through to that, 8-week point, 10-week point, whatever point it is that your REI's office have said, good luck, Godspeed. We've gotten you as far as we can go. You're off to your OBGYN. And so Shannon, as a maternal fetal medicine doc, has spent not only the 4 years in OBGYN residency that all of us spend, but where Susan and Abby and I went to do 3 years of infertility training, she went to 3 years of dealing with the hardest, craziest pregnancy complications that you can imagine. And so I really remember when we were in residency, we had this night float system. So someone would be on the night shift and someone would be on the day shift. And I loved coming on the day shift after Dr. Ho because she had everything figured out for me.
It's like a true MFM, right?
True MFM. Like she would just, all these disasters would gravitate to her, and then she would find out what was going on and she would fix them. And she would hand me this beautiful plan so that this REI minded resident who, like, I was totally fine at all the basic obstetrics, but good God, woman, I remember the cases you used to hand to me and I'm like, oh, thank God Shannon is on, because I could hand you anything and you would be fine. And you would hand it back to me. Just, all right, Bedient, this is what you're going to do. And then I would say, yes, ma'am. And it would be great. So thank you for coming with us today. And when you get someone who's coming from a fertility office, and for the moment, let's just start with basic pregnancy. So someone who doesn't have any of the huge diagnoses that automatically, unequivocally get sent to you. But when you get someone who's conceived after IVF, how do you approach that pregnancy?
Yeah. Thank you again for having me. It's my pleasure. I appreciate all my REI colleagues. You guys mean the world to me. And I had to walk a personal journey of having some infertility. I had imagined that, when I was ready to get pregnant, I would get pregnant, but lo and behold, it didn't happen. And so we ended up having to kind of do the full court push, and we kind of got up to IVF, and then we had experienced multiple miscarriages and then kind of took a break and then ended up having spontaneous twins.
Does that really happen? Spontaneous twins?
I know, the rare bird that it is. And so I see a lot of the IVF patients because at the time, it felt like the worst thing in the world that was happening. And unless you have walked through those shoes and had those trials and tribulations, you just kind of don't understand. So I end up getting a lot of the IVF patients because I think I have that kind of experience. And I think that's comforting to them to know that, hey, I'm not alone. Somebody else has been through this and they understand, when I'm having my crazy kind of neurotic moments that, it's okay. And so, I typically just kind of start off and kind of give them just a general overview. I do slightly touch on that we do see some more kind of first trimester losses in our IVF patients.
And I would like to interject, are we meaning truly IVF patients or any of our patients who have conceived after a history of infertility?
So I get both in my practice.
Because both are considered high risk.
Yes, absolutely. And so, I'm a big goal setter. So I say, if we could get to that, second trimester, we tend not to see an increase in loss after the second trimester. I do touch on that, we do see more of the monozygotic twinning in our IVF patients. And that would include the monochorionic, diamnionic, and some of the mono twins as well. So
hold on.
So in English terms, for a non-medical lister, what does monozygotic, dichorionic, what does all that mean?
That's the set of twins. So you have one placenta and two separate sacs. And then the one that kind of makes all of us clutch our pearls and sweat a little bit is that one placenta, one sac situation. And so I don't belabor this point, but I do think it's important to understand kind of what you're getting yourself into, especially when I get these patients, at 8 to 10 weeks. We have some talk about that. And then I usually kind of break it down into maternal and fetal issues moving forward, because my job is to kind of put in a roadmap and a plan so that their OBGYN and the patient, they feel comfortable and they kind of have a roadmap for where we're going and where we're heading, which I tell all my patients, my end game is I want you to go home happy and healthy, and I want you to take home a happy, healthy baby. And so however we got to do that, let's do it.
So Shannon, in your practice, and I would say most maternal fetal medicine practices, they're kind of like fertility doctors in that you guys don't actually deliver babies much, correct?
Typically, yes. If I have been called in, there's something disastrous that has happened.
I was going to say.
Most of my patients are like, I love you, Dr. Ho, but I don't want to see you. I will send you a picture.
Yes.
So you're working in conjunction with their primary OB-GYN.
Absolutely. So I think it's important to honor that relationship as well. So you tend to you get a lot of love in our system because you have your general OBGYN, then you also have your MFM, and then you've had your REI. So you have a big team behind you, and everybody's rooting for your success and trying to do anything and everything we can to get you to that finish line, which is a happy, healthy baby.
So how frequently do patients kind of bounce? And I'm sure it depends a lot on what the situation is, but how do you normally kind of have patients bounce back and forth? Do they see you one time and then a month later they see their OBGYN, or how does that usually work? Like with diabetes or something like that, for example?
So for instance, if it was like a gestational diabetic patient, a lot of times these are patients who have never had diabetes who will come and meet with us for a consult. We're kind of get them looped into the system of how to report their sugars, things like that, and help with the ultrasound standpoint of checking for fetal overgrowth, extra fluid around the baby, polyhydramnios. And they will kind of do those ultrasound appointments with us and then reach out to our office either through our electronic medical record, or they could call us with their blood sugars. And then we will kind of give them recommendations and guidance. And then when it comes to the delivery portion of it, we will make recommendations to their OBGYN as well. So there's a lot of we own the ultrasound component of it. We own kind of making the plan for how we're going to manage this pregnancy and any of the complications that may arise in the pregnancy. But it's truly a team effort.
So I get a lot of patients who are understandably anxious when they come, and we'll send a decent percentage of them for preconception counseling with you guys, just so they kind of know. And that's particularly if they're 40 or older. Obviously, if they have any other coexisting medical problems like diabetes or blood pressure or something where I know they're going to land in your lap at some point, I'll send them for preconception counseling. What do you tell them at that visit of someone who's like 40 or older and looking into fertility treatment to get pregnant?
So again, you could totally do it. I use the analogy of it's like having an antique car and you're driving between Cleveland and Columbus. It will get you to both destinations. Now, you may need to check the oil more frequently. You may need to rotate the tires.
I don't know if we should use that analogy with our patients. I don't know how they'd like that very well, but I like it, though. It's an interesting analogy.
You can buy a brand new Escalade and drive straight there, too, albeit, the young 20-something that just, has no problem with fertility, seems to get pregnant at the drop of a hat. So you can get to the destination. I just tell them they have to be prepared that there's going to be a lot more stopgaps and check-ins to ensure maternal well-being as well as fetal well-being.
And what's the oldest patient that you would recommend that it's still safe to get pregnancy? And what are some things that would make you think it's not safe for somebody to get pregnant?
So we actually have a very large Somali population here in Columbus. So I have some moms who have been upwards of 58, 59 years old that have been spontaneously getting pregnant. And, they're like, oh, well, I mean, my mom was like 56 when she had me. What's the big deal? And I'm kind of like, big eyes, like, oh, my word, I couldn't imagine. So we have a gamut of age ranges that we take care of in our practice. Some of the really hard stops for me would be if there is kidney failure. I don't recommend that those patients attempt pregnancy. Certain cardiac issues, really uncontrolled pulmonary hypertension. That's a real no-go for me. Poorly controlled diabetes, if they're willing to work and put in that work and get that diabetes under control, I'm not absolutely opposed to that. But again, diabetes kind of feeds in and you can have a lot of renal, meaning kidney issues, a lot of cardiac issues.
What are your thoughts on multiple C-sections?
Yeah, it's the nature of the beast is the way I kind of look at it. And, I'm thankful that we're in a place where we can deliver babies safely outside of just the old, routine vaginal delivery. And the fact of the matter is, in the way we practice, people are having more and more C-sections. I do think it's important to try to look for some of the things that can be associated with multiple C-sections, like accreta, meaning the placenta kind of growing into the uterine wall abnormally. And this is where I think MFM really comes into play. And I think if patients have had multiple C-sections, it's always good to send them in. Let us do our level 2 ultrasound, take a good look and see kind of what's going on with that placenta. A lot of times I bring these patients back because the placenta is not a static creature. It changes and evolves. And what it looks like at 18 weeks, you might not be getting the same thing at 32 to 34 weeks. So again, I just recognize it's kind of multiple C-sections. They're here to stay. It's not going away. And we just need to make sure that, again, moms are safe and kind of help their team look for any of the clues that can indicate something abnormal is going on, because knowledge is power. And when you know better, you do better. And if you know there's a chance that that placenta might not come out the way it should, it makes a world of difference in maternal outcomes if the team is prepped and ready for that.
How do you approach, Shannon? I get a lot of ladies, usually in the 45 to 50 range, who they either have embryos made previously or they're using a donor for eggs, and they're pushing really hard. And this is one of the biggest struggles that I have, is they're pushing really hard to transfer 2 embryos. And a lot of times these are made from donor eggs. They're genetically tested. And so we know that the chance of both of them sticking is really high. And I tend to come down. My husband, that my goal is to keep my patients and his patients 100% separated in this world, because I don't want anybody landing in the pediatric ICU with Mark. And so they ask a lot, like, well, can you transfer 2? Because if we wait another, let's say, year after having the first one, then we're going to have all these complications. And I'm like, I would rather you not have 2 at the same time, plus be 48, because I'm worried about compounding things. I'd rather you have a baby at 48 and a baby at 49 and a half, and click through it that way, rather than pile up with twins. But what's how do you approach those questions?
It's interesting. Just being 48 does predispose you to a lot more maternal issues. Preeclampsia is the most common. That's one of the most common causes of preterm delivery. is that disorder of pregnancy. And so to your point, Carrie, that risk goes up the more fetuses you put in there, the more placental tissue you have in there. So you're going to have a higher risk of preeclampsia. You're going to have a higher risk of gestational diabetes. So it's not without its issues having multiples. That being said, in my world, twins, really no big deal. Like we don't really start batting an eye till we start getting some of the higher order multiples, getting up in quads and things like that. That's when we start getting a little nervous. Having had twins and having had a singleton, I tell all my patients one at a time is definitely the way to go. It's much easier to carry one than it is to carry two. And you just have a lot less pain and suffering. And, you get a lot further along typically with the singleton. So singleton is hands down the ideal setup. I think that's where you have the best real estate for that placenta to set up shop. You have the most room for baby to grow. You cut down on your complications of preeclampsia, gestational diabetes. That being said, though, if you do land yourself in the market of multiples through no fault of your own, we can still take care of you. It's no problem. Twins, we're really comfortable with that. That doesn't really drive things into the kind of danger zone. Starting getting up triplets, quads, though, that's dangerous territory for sure.
Shannon, how often do you see cardiac issues, specifically cardiomyopathy, where the heart muscle just can't pump very well? Some of our MFMs have told me that sometimes even with twins and not infrequently with triplets and quadruplets, that long-term, even maybe a year or two after the baby's delivered, that they see cardiomyopathy in those patients where the heart muscle just doesn't pump very well. Is that something you guys see very commonly with multiples?
We can see that, with twins, every pregnant woman has an expansion of their blood volume by at least half. And you get a little bit extra with the additional fetuses that are in there. So you get a little over half. And so that definitely does put a stress on the maternal heart. So anyone who had any kind of underlying cardiac issues, that's definitely going to exacerbate and really open that door and make that really much more pronounced. We are also seeing a lot of pretty aggressive preeclampsia that fluid overload exacerbates the heart condition such that you get a cardiomyopathy that's associated with preeclampsia. Not the cardiomyopathy that is kind of like the textbook that we learned about in residency. That's the patient that's just fluid heart failure, but actually the preeclamptic process itself and the fluid overload puts a huge stress and strain on the heart, and the heart muscle becomes very dysfunctional. So I see a lot of that. Thankfully, if it's usually associated with preeclampsia, you treat the preeclampsia, you treat the problem, and those moms tend to bounce back and get their cardiac function back. Whereas some of my true, just straight cardiomyopathy patients may be walking around with an EF or ejection fraction of, 20, 30%.
Heart doesn't pump so well.
Yeah.
So it's very interesting. We see a lot of it, unfortunately.
So, we have lots of patients that have high blood pressure, diabetes, obesity, all those chronic health complaints. If somebody is going to go see their fertility doctor and they're like, what can I do to make myself be set up for the best pregnancy possible? What would you advise those patients to do?
Absolutely. So when it comes to the diabetic world, we like to see that hemoglobin A1C under 6, ideally, if you could get to that. That will set up the best intrauterine environment for the developing fetus.
What type of complications do you tend to see when it's greater than 6?
So we see more miscarriage. We see more congenital anomalies, meaning we see more heart defects. We definitely see defects with how the lower limbs kind of develop and fuse together or not fuse together.
What are you meaning by that?
So sometimes in moms who have really, really poorly controlled diabetes, the lower limbs, they almost look like a mermaid. They fuse together and it's like you have one lower extremity instead of two. And that is definitely driven by what the maternal blood sugar is doing. We see just a lot of congenital anomalies that's associated with poorly controlled diabetes, because basically the developing tissues, they really like a blood sugar that's down in the 90s to 100. So if you're having a blood sugar that's, continually 200-300 range, that impacts what's happening. And we're also learning that there's all this kind of cellular programming that we don't even realize that's happening in there, those high blood sugar switches that are being flipped that may predispose this little one to developing diabetes themselves, chronic health issues, things like that. So if we have the luxury of time and they're coming to me as a preconception consult, I say definitely for the diabetics, we got to get that hemoglobin A1C down, ideally 6 or less. We want to make sure that they are up to date and have had like a recent echo. A lot of the type 1 diabetics, these people who have been living with this disease process since they've been a child, it can really wreak havoc on the vasculature throughout the entire maternal unit. So I like to see a baseline echo to make sure their heart is functioning as it should, and it can take the stress and strain of pregnancy. I also like to make sure that they've had a recent eye exam, because anyone who's been through labor knows that's a lot of pushing and straining. Diabetics can be predisposed to retinopathy. I have had moms who have burst blood vessels in their eyes and lost vision because of the poorly controlled diabetes. So I know a lot of them are like, Dr. Ho, why are you sending me to an ophthalmologist? I'm like, but my job is to make sure that your whole person is okay.
Yeah.
When it comes to our chronic hypertensives, I think the number one thing is to get their blood pressure under control. We want to see that systolic under 160, the diastolic under 100. And we try to stay away from certain blood pressure medications. Like if you know you're going to get pregnant, we don't want you on lisinopril because that can damage the fetal kidneys, things like that. And just try to optimize their medical regimen going into pregnancy.
What about the patients who are kind of on the heavy side of things? What do you usually tell them? And what kind of weight do you really kind of get really worried about in terms of labor and delivery complications?
Yeah, we have a huge problem with obesity here. I think I just had a patient that had a BMI of about 78.
So what kind of height and weight roughly would that be?
Yeah, so she was about 5 feet tall and close to 500 pounds. So it wasn't that, unfortunately, it wasn't stretched out over much. And so that can be an issue with having an increase in cesarean section and things like that. I have been a variety of weights in my life. And so I am very open and honest with my patients. And I just level set and tell them, weight loss, it's more about the absolute healthy habits and the lifestyle changes than any one radical diet that you could do. I recommend a lot of Weight Watchers because I think that program works and it makes them more aware and accountable. I also try to get them started on some form of exercise. And I explained to him, it doesn't have to be sexy. It could be 15 minutes of walking in the morning, 15 minutes of walking in the evening. We are here in the Midwest, so we do have winters and bad weather and things like that. And I tell them, if you go to like an indoor mall area, even a big super grocery store,
Yeah, Costco, Sam's.
That gets really expensive though.
I know, right?
Yeah.
And so, if they could start on that and get some of that weight off, every little bit helps. Some patients, have been considering gastric bypass surgery and things like that. And I think that can be a huge help. I typically recommend waiting at least 1 year after any of the gastric bypass surgery to kind of let everything settle out, heal, depending on what they have done, whether it's gastric sleeve or some of the more aggressive, Roux-en-Y type procedures. You need about a year ideally after that. And then if you have one of those procedures, then there is a little bit different monitoring of the different nutrients and so forth to make sure that, again, baby's getting everything that it needs and the mom is getting everything she needs.
On that note, when we all have lots of people who have had gastric sleeves, gastric bypasses, lots of gastric sleeves nowadays. How do we best serve them to get them all those micronutrients that they need and they can't swallow the typical prenatal that we're recommending for everybody else?
Yeah, I'm a big fan of using just the gummy vitamins. I know in pregnancy, nausea and vomiting, even if you've not had any of the gastric manipulation, it's a huge thing. And it can be really hard to swallow those prenatals. They seem to make them inordinately large.
I mean, size matters.
Yeah.
Huge pill going down your throat. So I will lean a lot on some of those things. And then as far as the different micronutrients, unfortunately, you just have to test. So in my moms who have had that, I will help work in conjunction with their OBs to make sure each trimester we're checking on certain vitamin levels and making sure that that's appropriate and they're getting what they need. Now, I will be honest, a lot of them, especially if they went through some of the weight loss centers and things like that, they really have it down to pat. And a lot of them will be coming to me already on this. But again, with just the changes in physiology from the pregnancy, we still check in on that stuff to make sure everything's on the up and up. But gastric sleeves usually do great. The more aggressive Roux-en-Ys can have more complications, for sure, more issues with nutrient absorption.
We don't see as many of those nowadays as we used to.
It's mostly the bypass, like the sleeves and that variety.
No.
So, well, thank you so much for coming to play with us, Shannon. If you had any particular recommendations or, words of advice for our patients who are, just about to make the transition from their REI office to their OB or their MFM's office, or people who are starting this process, any words of advice, anything you see from your perspective that you want as many people as possible to know?
I would want them to know that, it's a marathon. It's not a sprint. And we are there for them and we're happy to help them and take care of them. I guess one of the number one things I would want to tell them is that, I get a lot of patients that they have done the pre-implantation genetic testing. And so they have the feeling they're like, okay, so my baby's going to be perfect. And that doesn't rule out congenital anomalies.
Yeah.
We try and tell them that, Shannon. They just may not hear it, but we try and tell them that it's not nothing's ever perfect.
Right. And so, I do think it is super important that these patients get in with an MFM. I think it's important that they have a level 2 ultrasound and at least one growth ultrasound at 28 weeks to check in on growth and fluid and make sure everything's okay. And any of the other issues that crop up, whether it's a placenta previa or growth restriction or preterm labor, preterm delivery. I mean, that's our wheelhouse. That's what we do. So we're here to help them, and it takes a village, and that's okay. And whatever they're feeling is totally normal. And if, they are stressed or worried, we've literally probably seen it all. So there's nothing that's too crazy, that's too out in left field for us to handle. And again, our goal is we want moms to be happy and healthy, and we want them to take home happy, healthy babies.
That's awesome. Yay. Well, thank you so much for coming to hang out with us. It is a pleasure to see your sweet face and hear your voice. And we are very lucky that we got you to record this afternoon. So thank you. To all of our listeners, thank you so much for tuning in, and be sure to tune in next week for more, and be sure to subscribe, leave us a review on iTunes. We very much appreciate it, and we love to hear from you.
And don't forget, you can also visit us on fertility.suncensored.com to schedule an appointment with any of us, or if you have specific questions that you have about fertility, we'd really love to answer them. And also any suggestions about segment ideas would be great too. So don't hold back. The more embarrassing, the better.
All right. We'll see you next week.
Bye.
Bye.